The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED podcast, critical care and emergency medicine education for nurses and paramedics.
All right. Hello, everyone, and welcome back to the FlightBridgeED MDCAST. My name is Mike Lauria. I'll be your host. I'm an emergency medicine, EMS, and critical care physician with a particular interest in critical care transport. And today we're going to begin our series called The Bleeding Edge on trauma. And we have a very special guest today as we're going to be discussing finger thoracostomy, which is an up-and-coming topic with more and more services using this particular skill. I'd like to introduce Dr. Bryce Taylor. He is a physician who did emergency medicine residency and is currently doing a flight fellowship up at the University of Wisconsin. Our amazing friends up at MedFlight, one of the only physician-based flight programs in the U.S., really the only one, on par with some of our European and Australian colleagues. So tell us a little bit about yourself, where you grew up, where you did undergrad, medical school, and how you got interested in a lot of the critical care transport stuff.
Yeah, so I grew up in Northern Virginia in the Washington, D.C. suburbs on the Virginia side. I ended up going to Virginia Tech for undergrad, where I actually started in volunteer EMS, advanced life support provider down there, pretty much all through my studies. After I graduated, I went and did a master's degree and then my medical degree at DeBusk down in Tennessee. Once I graduated, I went back to Virginia to Roanoke, where I did residency at Virginia Tech Carilion School of Medicine at Roanoke Memorial Hospital. While there, I really liked all the trauma, really loved all the critical care. We had a really robust 3-base nurse medic flight program under Dr. Haley Rose Inman. I was fortunate that she kind of took me under her wing and let me come along to do protocol development and medical direction. And then I also flew a ton. And that's kind of how I ended up getting into the mid-flight fellowship.
Well, fantastic. Welcome to the podcast, dude. As always, I try and get amazing guests on here that actually have experience doing critical care transport. And so flying around and actually understanding what it's like to land on the side of the road at 2 a.m. having to treat a really, really sick trauma patient. So without further ado, let's start talking about finger thoracostomy. So as many of you in the audience know, the reason that we do finger thoracostomy is for tension pneumothorax. And that's an important distinction. And I know we say it all the time, but sometimes I feel like those words don't always ring true. And I'm sure Bryce has had experiences, as have I, in the emergency department where someone maybe has some rib pain and they desat to 88 for like a split second and they come in with needles and catheters hanging out of their chest. So let's just really quick define the population we're doing this on, Bryce. So let's start out with what is the difference between tension and there's a tension pneumothorax and a regular old-fashioned pneumothorax.
Yeah. So I think that when I teach this, I kind of go into like 4 populations. I kind of go trauma, medical, and then under both of those, you have tension and then non-tension. As far as this podcast goes tonight, we're talking about trauma, so I'll kind of stick to that. But you can have a pneumothorax without having tension physiology. So actually, I would venture to say most pneumothoraces are not with tension. I know in the trauma bay, we would get pneumos all the time that we actually would just observe because, they were less than 15%, or some institutions use less than 33 millimeters, 35 millimeters on CT scan. They'll just do serial chest x-rays and pulse oximetry, and they resolve themselves. Now, when you start to get signs of cardiovascular collapse, you get the famous mediastinal shift, the tracheal deviation, the tachycardia, the hypoxia, the hypotension. Those things are really life-threatening, and then that's when you want to rapidly decompress. Now, these people that have these massive traumas that end up going to respiratory failure, I know a lot of times we will go straight to the needle or straight to the knife just because of the respiratory failure from polytrauma. Now, there's still kind of they're still exploring as far as that goes. I don't have really any good answer as far as whether or not you can just declare something's a tension based on respiratory failure alone. But yeah, so basically I just kind of define it as hemodynamic instability or impending hemodynamic collapse.
I think that's a pretty good way to think about it. The hemodynamic profile being like the defining factor. I mean, there have been some discussions of, defining, sometimes I feel like, and, correct me if you think I'm wrong, sometimes people come in the emergency department into the trauma bay, they look really sick, and you're like, oh man, this guy's got like a tension, and they're fine, lungs up, everything looks great. And because they're polytrauma, it can be really difficult sometimes to really weed that out. I would say there's a couple of exceptions, right? Like just broken ribs, subcutaneous emphysema up the wazoo, like stuff like that. That's like clearly there is air outside of the lung in the pleural space going into the subcutaneous tissue. This is a pneumothorax. Couple things. First of all, I'm interested to hear your opinion. So we talk about hemodynamic compromise. I definitely feel like I've had patients that are tensioning. They are maintaining a systolic blood pressure of like 98, 102, kind of hanging in there, but their heart rate's in like the 130s or 140s. Technically, they're not hypotensive, but they're compensating. How do you draw the line in your mind between this is tension physiology and I need to intervene, even though maybe the number's not like his systolic blood pressure is not 70 versus someone who's really sick and you think they're going to be systolic blood pressure 70 really soon?
Yeah. So I think having a good gestalt as far as where things are going to go is really important. You don't necessarily have to be hypotensive to necessarily be in shock, especially in young people. They can be compensating well for the moment, whereas, give them a few minutes, it'll fall apart completely. And at that point, when you're doing the decompression, you're kind of chasing your tail almost. So I think taking the full clinical picture into mind, there's also the shock index I will sometimes employ. I really like the shock index. People kind of use it more or less, depending on what is the pathology behind what they're evaluating. It started off with trauma as being kind of like a predictor to transfuse, but I think that it's a really good way to pick up a cult shock because, having a higher shock index is not really normal for anybody. If they are having these pulmonary symptoms, they have a mechanism, and then their shock index is going up and not going down. I think that you have a good reason to look further into doing a decompression.
Yeah, absolutely. And for our listeners who may be just hearing about shock index for the first time, would you mind just like defining it for them? And then like what shock index would have you pretty concerned?
Basically, a shock index is a formula that you get based on the systolic blood pressure and the heart rate. There are calculators out there, but Dr. Rose Inman taught me something really easy because I don't like to really necessarily sit there doing math on the side of a road. So if the heart rate is higher than the blood pressure, so like if the heart rate's 110 and the blood pressure is 90, you're going to have a high shock index. Now, technically, where a high shock index is kind of depends on who you talk to, the institution. I kind of go with a shock index of 0.8 to 0.9. Definitely 1 or more, I would say, is beyond abnormal. But that's kind of, it's an extra data set that I use. I don't like hinge everything on it. So like I never use it alone to make a decision, but in addition to everything else I'm finding, it's a good way to really kind of get a bigger picture.
Yeah, I agree with you 100%, dude. And I like that trick because that's basically what I use. I agree with you. The literature, depending upon what you read, I think the majority of it, the cutoff is around like 0.9 in terms of hemorrhagic shock, needing transfusions, more likely to die, etc. But I use 1. I do exactly what you do because it's easy, right? If you look at the systolic blood pressure and the heart rate, if the heart rate is greater than the systolic blood pressure, right there, you're above like 0.9, you're above 1, right? The ratio is above 1. Whereas normally most of us should have a shock index of like 0.5, right? We should have a systolic blood pressure, heart rate in the 60s or 70s, systolic blood pressure 120s or so. So when that gets inverted and your heart rate's 120 and your systolic blood pressure is 60, that's bad. So here's a question for you, my man. On med flight, when you're flying and operationally responding to a super sick trauma patient that you're that you are reasonably sick. Let's say, because it seems like there's always like this bimodal distribution. You get there, you land, you get out of the aircraft, it's like they're about to die, right?
Yep.
Or they're actually not doing so bad. It's like one of our old ranchers in New Mexico is just sitting there asking for a cigarette, and he's like all broken, but he's doing okay. And rarely there's like that handful in the center that I'm like, he might have something going on. Looks like he's in a little bit of respiratory distress, but doing fine on a nasal cannula, maybe a little bit tachypnic in the high 20s. Are you ever using ultrasound on scene to actually see if there is pneumothorax present?
Yeah. So actually, I do. So I love like resuscitative ultrasound. So I do not just for like my traumas, but like my medicals also. I'll do basically it's almost like a modified rush. So I'll look at heart, lungs, and IVC, and it's actually really good for the pneumos and then the hemos especially. I feel like it's even better for the hemos because you can like just straight up see the volume inside of the pleural cavity. So with ultrasound, going through residency, we all kind of go through the motions when we get a trauma. We do the EFAST. We do 2 lung points, like mid-clavicular, and say it's a negative EFAST. So one thing I make sure that I always do with my traumas when I'm looking at their lungs is I check 3 points. So I do mid-axillary, I do mid-clavicular, and then I try to get posterior and inferior kind of like along where the diaphragm meets, because you kind of want to get all 3 dimensions within view. Because having good lung slide in one part doesn't mean you have good lung slide all over. And we actually on MedFlight do find lung points all the time that way. I would say that pretty much every non-code decompression that we do, we will do an ultrasound beforehand. And then with Curly and Lifeguard, during my 3rd year, we were rolling out a similar protocol to bring ultrasound into resuscitation as well. And the 3-point was, a big emphasis as far as their training went as well. One important detail I do always teach my residents and med students is that the ultrasound is really good for picking up a pneumo, but if it's a negative ultrasound, that doesn't mean that there's not a pneumo. Really, you need a CT scan to really say yes or no. But usually, if it's a big enough pneumo to be causing hemodynamic collapse, you're going to find it.
Yeah, agree there. And I think for me, at least, I'll be honest, I don't do it all the time. You get in the back of the ambulance, you open up the door, you look at him like, oh my gosh, this guy looks like he's about to die. If they're doing CPR, it's pretty straightforward. He's going to get empiric finger thoracostomies. If they look really sick, more likely to do it. But that middle population, I really feel like it helps. Because if you identify the pneumothorax, and they're just a little tachypnic, but their hemodynamics are fine, you can sit on it and you can wait and you can say, hey, this is what's going on. I don't think we have to drain the air out of your chest right now. We'll fly out of the hospital. But that way, both you and your partner and the patient have a shared mental model that if things get worse, if their blood pressure drops and there's pneumothorax, you know exactly what you got to do, which I think is helpful.
And it's also a pretty good dynamic tool because we can do them up in the air as well pretty easily. So we can always reevaluate.
Yeah, I think that's a great point, and especially in an environment where you can't really hear anything, and it can be difficult to, evaluate your patient sometimes. Re-examining them, serial examinations may be reasonable, but I agree. Most of the time, I'm not really doing that in the air. So let's say they have a tension pneumothorax. You are positive. They have multiple broken ribs, subcutaneous air for, just for fun. You throw the ultrasound on there real quick and show everybody, there's no lung sliding. Let's just get out the old 14 gauge, right? What's wrong with just needle decompression?
I mean, it's always an option. We do carry it in our bag. It wouldn't necessarily be a wrong answer for sure in the United States. I honestly have not ever seen a needle work coming in from pre-hospital. Either the lung is up because the needle is in the lung parenchyma on the CT scan, or they didn't have a pneumo and the lung is in the soft tissue, or they have a pneumo and they have a needle in the soft tissue. There's studies that are more and more frequently coming out that needles are either not long enough, they are not mechanically capable of maintaining a valve or a conduit, and that they are placed wrong more than 80% of the time, to the point where ITLS, ATLS, and PCCC have all moved to saying finger thoracostomy is the first line for a decompression. This has been over the past 5 or so years. I will say that the needle is probably more effective in the mid-axillary than it is in the supraclavicular region. midclavicular, based on the amount of soft tissue that there is. So you're going to have more soft tissue and muscle up in the anterior chest than you are going to have along the lateral chest. The other instance where it might be worthwhile is like if you're trying to bridge someone. This is going to be especially relevant in combat tactical medicine settings where you might not have a lot of time to knife, but you have some time to do a needle, and then they have body armor on. So you can reach the mid-axillary area. But I think other than that, I would just move straight to the knife.
And that's a very reasonable move. I know we've been a little bit more conservative about it at our shop. We've encouraged people to at least, if you can, try with a needle. More and more, I question that and feel like, especially if you're hypotensive, if you're hemodynamically compromised from tension physiology, it's probably reasonable to just move directly to the finger thoracostomy. I agree with you. And I think it's interesting if you look at the evolution of it, right? There were those early studies in healthy soldiers and sailors that showed if you had like the 3.25 inch needle, that would be long enough to access the chest of more than 98% of people. 98% of people in that study, which was like young, healthy people, and more as we see in the civilian environment. I'm sure everybody's patients may be slightly fluffier than a healthy 22-year-old Marine. So we see that it really doesn't get in the right spot. If it doesn't get into the access the pleural space, even if you put it in the right spot, which, as you mentioned, a lot of people don't. The majority of people don't, which is kind of scary, actually. But it also goes to speak for the stress that you're under. Trying to find the right anatomical landmarks on people is absolutely challenging under these circumstances, which brings us to my next point. So you're going to do the finger thoracostomy. You got your scalpel out. You're ready to rock and roll. You're about to clean off the skin. Where are you going and how are you finding the landmarks?
It is kind of a skill you have to use. I know with lifeguard, they all found it on each other. Pretty much on every flight crew member, they would all find it on someone else to the point where they all found each other's pretty much in completion. Because every body habitus is going to be different. There's going to be structural changes, that are very independent of each other and very individual. But the way I was taught was that you use the triangle as being the inframammary crease along the fifth rib. You use the lateral edge of the pectoral muscle, and then you use the latissimus dorsi line up the posterior mid-axillary region. Inside there, you have the least likelihood of causing injury to another structure, and you have the most likelihood of getting into the chest.
One of the other tricks that I was taught, which is a practice, I don't have necessarily any evidence to support this, but I've been trying to actually do a study where we look at this, is on healthy cadavers. We've been actually able to see that if you take your hand, basically the palm of your hand, this works on adults to adults only, and basically jam it up into the axilla with the arm at about 90 degrees, it's going to put you about halfway down that triangle of safety. And I feel like that's enough to keep you away from the great vessels. But high enough to make sure you're in the right space. Because again, I don't know what your experience has been both in and outside of the hospital. I would much rather people be a rib space or two high than low. I've definitely seen a lot of splenic and hepatic biopsies. I have not seen laterally a lot of needles end up in like an axillary artery or anything like that.
That's kind of a trick that we taught lifeguard as well.
Nice. So, if one of the questions that I think has come up on a regular basis is, if you're going to do this, right, why don't you just put in a tube? You're already halfway there, right?
I think that's a very valid question. Some places do put in tubes. I think in the field, the likelihood of getting a sterile environment is very low. I think if you're doing an inner facility where you go to a room, and this will actually happen up here sometimes, they'll call us, they'll set up for the chest tube and like have the chest tube tray out and all that. We'll lock in, sterilize, and put the tube in, but that's in a room under a controlled environment. If you're doing a finger thoracostomy in the back of an ambulance, that's going to be the most controlled setting you'll be doing it in the field, if not in a ditch or on the ground in the woods or wherever else you might find yourself. Putting in a tube is not wrong, but The likelihood of an infection from the tube, I would say, is higher. And I've not found any hard evidence for this. I'm just kind of going off of kind of my empiric knowledge of indwelling hardware being placed in less than sterile conditions. And then I also, in my experience with trauma surgeons, they will pull out anything that you put in before you show up. So you can put the tube in. Now, if you have the bandwidth for suction, that is another thing to consider, because the tube really gives you better benefit when it has suction rather than just being a conduit. If not, then it might as well just be a hole that you re-decompress. When you show up, they'll put in a chest tube. They'll actually make a hole above the rib space that you did yours in, just based on infection risk.
I think it'd be interesting to look at chest tubes versus finger thoracostomies in the field and rates of empyema. A couple things. I think we underappreciate in the pre-hospital setting. We'll just say, well, we got to save their life. We got to do what we got to do, and we'll treat the infection later. I will say that pleural space infections, empyemas, managing those in the inpatient setting, managing those patients in the ICU, in the trauma ICU, in the medical ICU, pleural space does not have a lot of really good blood flow. It can be very complicated to treat. It's not very easy to treat, and it can lead to a lot of really bad complications. That pus forms pockets and sticks to the lung and causes all sorts of issues. So it's not an insignificant infection. It's not just like a soft tissue infection, guys, that we can like throw a little bit of antibiotics at and you're going to be fine. It actually creates a really complicated infection. Number two, I agree with you, Bryce, man. I think that the likelihood of a pathogen growing on a piece of plastic, a non-living thing in a space that's not well vascularized, is probably higher than just going in and out really quick. And third, honestly, I mean, if you look at the literature, right, the rate of complications from the tubes going in the wrong place or hitting the lung or going into or causing damage and being misplaced in the skin, the subcutaneous skin, after decompressing the chest, right, is actually pretty reasonable. So I think it's probably okay. And some people disagree with me on this one, but if it's, if I'm at an outside hospital doing a retrieval from like a place 2 hours away in a very remote setting, maybe if I can control it, if I have a control environment. But I agree with you. Probably in a trauma where I'm flying directly at a trauma center, just do the finger thoracostomy. One of the questions that comes up, man, is, is it safe? We have, I get questions all the time from teams in the hospital, like, the nurses and paramedics can actually access the chest with a scalpel? And you're like, yeah, they're pretty good. They're pretty darn good at it. But is there any evidence to say that it's actually safe and reasonable for nurses and paramedics to do this procedure?
So there are multiple studies. Most of them at this point are from overseas. So as far as their generalizability to us, it will vary based on like differences in education. That's also going to be dependent on, where you are as far as like the state and what that allows for. I will say that I think that this, in my opinion, I think this procedure is safer than an RSI. You are doing one incision and you're sticking your finger in with the blunt needle or the blunt Kellys, and you're feeling what you're doing. Whereas like an RSI, you paralyze someone, you don't know if you're going to get that airway. So, you can be relatively sure of it, but who knows, right? Now, there are studies that will show between 0% and 10% complication rates after finger thoracostomies in the field. They actually did a study where they did a 1-day course where they did didactics and then a practical where they taught not just the procedure, but safety around the procedure, sterility, and then like chest physiology, maintaining the open conduit to continue the release. And they found no significant complications. They had 2, I believe they were like lung lacs, and then 1 incidence of cellulitis. Otherwise, they got all correct placement based on their review of the cases. And I believe there's like 59 cases. Mm-hmm. Now, I will say that with the caveat that all those patients had very high ISSs and that they were generally being coded at the time of placement, and more than half of them did not even make it to the hospital. So whether or not there were more complications, we'll never know. But based on the ones that did make it, there was a very low complication risk. And then they're actually looking at this down in San Antonio with ground paramedics, where they have been doing basically cardiac arrest finger thoracostomies. And they found 10% or less are getting complications. I think as far as procedures go, it's definitely not going to be the most dangerous procedure that they can do. It's not going to be one of the most common procedures they do either, though. So I think there will be anxiety around that component. But as far as safety, I think it's a very safe skill to be releasing.
Yeah, I think I'll come back to the medical director side of that in a second. But before I ask you about that, I really want to touch on one thing, which is anytime we do a skill, especially in the trauma setting for people who are super sick with a surgical pathology that may need definitive surgical intervention, we always worried about like time, right? Anything that takes more time and gets them to a place where I can give them more blood, I can give them, they can be stabilized and taken to surgery. Always concerned about that. Is this procedure pretty lengthy? Like how long do you think it takes the average, at least reasonably well-trained nurse, paramedic, flight physician to do this procedure?
Yeah, I would venture to say that it would take less than 30 seconds each side. I know the way that we taught lifeguard was that they both come up on each side. One does one, and then they pass the scalpel, and the other one does the other side, and then they go on to the rest of the resuscitation. That was also something that they looked at in San Antonio as well, regarding the time on scene as far as the additional morbidity. And they found no significant differences in scene time, transport time, or time to the trauma bay. So I think as far as time intervention, as far as that paradigm goes, I think it's definitely something that's worth it, especially if you're going to relieve life-threatening, it's literally one of the H's and T's. If you can relieve that before you start traveling, you can make a transport a lot less eventful.
So getting back to the rollout, now I want to just kind of transition. We talked about the procedure. We talked about when to do it. So indications, we talked about that we talked about the challenges, at least with needle thoracentesis and why it might be better and how you do it. Now, for our listeners who may be quality officers in their organizations or training officers or part of the educational cadre or even preceptors, in terms of training people to do it, how did you guys roll it out? And then what did you consider in terms of performance that says this credentialing, this person's good to go, they can effectively perform this skill, and then continuing education and continuing competency?
So, of course, it's going to be dependent on your state, kind of if you can even roll it out. So that's going to be the first thing that you have to really look into. Virginia had brought it within the scope of paramedic nurses, I think a year or so before the protocol committee even started thinking about it. The rollout or the development of the protocol actually started before I was even a resident there. Shannon Paetzel's one of the flight nurses that's been at Lifeguard, I think 12 or 15 years. And she is very involved with the protocol development, protocol rollout. She found out about the finger thoracostomy protocols at Boston MedFlight and Memorial Hermann Life Flight. And she actually talked to one of the trauma surgeons at Memorial. And that's how she got the idea that, this is something that we should be bringing to Lifeguard. We have, a high percentage of these scenes that are these massive polytraumas. I'm sure that's a lot of these chest traumas are dying because of, chest pathology. A good big percentage of them coming into the trauma bay are getting chest tubes with large outputs of air and blood. So, how much more stable could we have got them on the way here before they're chasing their tail as far as resuscitation goes? She approached the protocol committee and the medical director, Dr. Rose Inman. Now, once you get that idea, you have to make sure that there's several parties involved that are going to be on board. So, does the flight crew actually want to do that? Do they have the bandwidth to learn that new skill? Are they in a good staffing position where they're not being overworked to fill holes in the schedule, where they're not going to have, time to learn this skill or to keep this skill up? There's also the medical director. Is the medical director willing to release this skill for the paramedics and the nurses? Some feel that their agencies are not ready for it, and that's completely within their purview. You're also bringing these people to not just the medical director, though, because you're bringing these patients to the trauma bay, which has both the emergency medicine faculty and physicians that are not necessarily involved with the EMS side or even know anything about the EMS side. And then you have the trauma surgeons. We were pretty lucky at Carillion because there was a really good relationship between the trauma and lifeguard and, the pre-hospital setting. So really, once it became an idea, it was just to figure out if this is a feasible thing, figure out if this is a reasonable thing, and then, figure out how to make it work. Once everybody was on board, they started to draft the protocol, which is basically Like if you read a procedure note for the placement of a chest tube, it's basically that up until where the chest tube goes in. So it's a very simple flow sheet, and the indication is traumatic cardiac arrest. That's not isolated head. So, you might want to, as far as like things went for us, we started with where it was the last ditch effort to get a heart rate back. And we kind of use this as a way to validate that it could work and it would work. After that, it's just a matter of training.
And did you guys eventually approve it for tension pneumothorax outside of traumatic arrest?
So that is in the process, this cycle, I believe.
Nice.
We wanted to have at least a year under our belt of getting these because we wanted to have, at least double digits as far as the procedure goes. For cardiac arrests, there's kind of like a myth that we don't transport cardiac arrests. And it's like, no, actually we do. But like we try to get the heart beating before we transport, like you can still call us. So that was something that we were working on there as well. We're at about 11 now, I think. And we're 100% successful. We've gotten ROSC on 3 of them.
Nice.
With our success rate, they're going to advance to, there's a verbiage that's used in the main life flight protocols. That is, if the patient is in extremis, and that kind of lets the crews decide, they can critically think, does this person need a finger thoracostomy for their tension pneumo?
Mm-hmm. Nice.
Now they're also rolling out ultrasound, so that's going to be something that can help as well.
Nice, man. That's good. So we're they're kind of bringing it in slowly. Started out with traumatic cardiac arrest, where it's absolutely indicated, and the benefit certainly outweighs the risk, and then kind of bring it into the non-traumatic patient. When you were teaching it to people, did you guys use, did you use porcine ribs? Did you use mannequin? What did you guys use?
So we used TraumaMan, which is like a mannequin that is made specifically for tension pneumos and like decompression chest tubes. But we also used the porcine ribs. Basically, the TraumaMan let them feel the landmarks pretty much is what it was best for. And then they could, cut down, pop through the synthetic pleura, and then kind of feel the mechanical lung. Whereas the porcine is really good for actually like feeling what the pleura feels like when you stick your finger through.
Yeah. That feeling of like popping through with the hemostat.
Yeah. And that's actually what I learned on as a med student was the porcine model. Mm-hmm. There are certain companies, I think it's called like Teleflex, that will do like cadaveric finger thoracostomy training. Mm-hmm. But I know that like resources for cadavers can be kind of usually limited to like the med students and the residents. And sometimes the finger thoracostomies are all done by the time they get to the flight crew.
Nice. Yeah. And I think for at least in our situation, because we did something pretty similar, it's not like an everyday procedure. So we were able to essentially QA, QI, all of them, every single one. And was your experience similar?
Yeah, 100% of those go to QA. They get reviewed by Dr. Rose Inman personally. And then they are all verified by the accepting physician when they roll into the trauma bay or post-mortem. So the site is actually verified as well.
Yeah. Yeah, that's definitely one of the benefits of that when they come back to our trauma center. We can either personally or on the CT scans or whatever, we can actually verify that it was in the right spot. The one question I did want to run by you, and this is kind of sort of a scenario question, which has kind of come up, and I love addressing these questions because they're pretty real world. I have some thoughts on it, but I wanted to run it by you. Is the questions come up of you have a really sick polytrauma patient who has chest injuries and pelvis injuries and abdominal injuries. And the question was posed to me, well, how do you know if, you're really trying to move quickly and resuscitate this person and fly them, and maybe you don't necessarily have time to sit there and do the ultrasound malfunctions or something happens, and you're like, is this person hypotensive because they are in hemorrhagic shock or obstructive shock from a tension pneumothorax? Do you decompress? How do you approach that?
Yeah, so I approach all trauma that is hypotensive as being hemorrhagic until proven otherwise. I definitely would start, the volume product resuscitation. They'll probably most definitely be coagulopathic as well. So getting the plasma started will help as well. my thing with resuscitation is that you can do more than one thing at once. So while you're starting the blood product resuscitation, you can also be cutting the chest. I think in like these really sick polytrauma patients, doing an empiric decompression on both sides is completely reasonable. And if you don't do it there, the likelihood of it getting done in the trauma bay anyways is going to be high. So, it's going to take a few seconds for the patient to start responding to the blood product volume. So, you can't say, yes, this is definitely hemorrhagic. No, this is not hemorrhagic. Yes, this is obstructive. No, this is not obstructive. Most of them are actually even going to be like a mix, I would say. So, yeah, no, I think an empiric finger thoracostomy without doing the ultrasound first is completely reasonable.
A couple things. First of all, I think it's a largely academic question that won't get sussed out until it'll be a question that's answered in retrospect, right? We rule out all those other things when they've been scanned, when they're up in the ICU, and we're like, that actually didn't have a focus of bleeding. In the field, I think it's really hard. It's still really hard for me. I think any of us who have even gone through paramedic school, we got through medical school, you go through residency, you go through fellowship, still can be really hard. And I think I really want to emphasize the point that you made, that things can be done in parallel. So I would absolutely start blood, plasma, the whole 9 yards to actively resuscitate this patient, assuming that they were bleeding someplace, and then move to the finger thoracostomy. As long as there's some reasonable evidence of chest trauma, then I would absolutely do it. Because let's say you decompress their chest and boom, now their blood pressure is like 110 over something, goes from, like 80, 70 over something, 8 over to 110 or something miraculously. You can always dial the blood products back. And if they get a unit of extra blood, there's risk associated with transfusing anybody. But in this situation, I think the benefits would outweigh the risk. More often than not, is you're expecting that giant rush of air, and you get a rush of air and you release some tension. But guess what? They're still hypotensive. They still need the blood because they're still probably bleeding somewhere after they got hit by the city bus or the Mack truck or got run over by, like a giant tractor or something like that. So I think, Bryce, this is awesome, man. Thank you so much for bringing your experience, both in the operational flight side and your experience as an assistant medical director, rolling a lot of this stuff out or helping to roll it out with your awesome team there. We talked about basically, again, just reviewing real quick, the indications. Make sure that there's evidence of hemodynamic compromise. Just because someone's having trouble breathing and their SATs may dip to 90 and they have some rib fractures doesn't mean they have a tension pneumothorax. You should stick your finger in their chest. Why not the needle? Well, we know it's less effective at actually decompressing, and a lot of the time we're not even in the right spot. And when someone's really that sick, I want to know I'm in the right spot. I want to know that I'm getting air out of the pleural space. We also reviewed some of the literature that it seems to be safe and reasonable. Nurses and paramedics, even though this appears to be an invasive skill, and I agree with you 100%, our teams do much more dangerous things like RSI and a whole bunch of, administer a whole bunch of drugs that have a lot of side effects. So I think this is, of all those things that we do in critical care transport, relatively safe. And we know that, or we have some data that suggests that it doesn't waste a lot of time in the field. So it's probably reasonable. And then we talked about some of the stuff in terms of training and education, which is important. Bryce, thank you so much for joining me. We really appreciate it and hope to have you back on future episodes here. Well, for now, take care, everybody, and fly safe. We'll see you on the next episode of the MDCAST.